Today's lecture covers overview to nervous system, the sympathetic effects on the body, adrenergic receptors, their types and their effects on the body, definition and classification of sympatholytics, classification, mechanism of action, pharmacokinetics, clinical uses, adverse effects, and contraindications of adrenergic receptor antagonists, key points about adrenergic neuron blocking drugs, central sympatholytic drugs, and ganglion blockers. Overview of nervous system. The nervous system is broadly classified into the central nervous system and the peripheral nervous system. The central nervous system integrates the received information and coordinates activity of all parts of the body and includes brain and spinal cord, while the peripheral nervous system includes neurons and ganglia located outside brain and spinal cord. It connects CNS to other parts of the body and includes somatic, enteric, and autonomic nervous system. Somatic nervous system is voluntary in nature and controls the movement of skeletal muscles. Enteric nervous system controls the activity of GI, while the autonomic nervous system is involuntary in nature and is subdivided into adrenergic, or sympathetic nervous system, and cholinergic, so-called parasympathetic nervous system. Sympathetic nervous system is the system deals fight and flight condition, and the main neurotransmitter is epinephrine and norepinephrine, while in cases of parasympathetic nervous system, it deals rest and digest phenomena, and the main neurotransmitter is acetylcholine. This figure shows somatic nervous system and autonomic nervous system. In somatic nervous system shows that the central body is located in the CNS, from where axon is released and runs in the peripheral nervous system and ends on the target tissue, where the acetylcholine is released. In autonomic nervous system, it is divided into sympathetic and parasympathetic division. Sympathetic division follows two patterns. First pattern shows that the cell body is located in the central nervous system, from where the preganglionic fiber runs in the peripheral nervous system and ends at ganglion, where acetylcholine is released. From this side, the post-ganglionic fiber originates and ends on the target tissue, and the neurotransmitter is norepinephrine. The target tissues are smooth muscles, glands, and the cardiac muscle. The second pattern is that the cell body is located in the central nervous system, from where the preganglionic fiber runs in the peripheral nervous system and ends at adrenal medulla, where the acetylcholine is released, and from adrenal medulla, the norepinephrine and epinephrine is released on stimulation. The target tissue is blood vessel. In parasympathetic nervous system, the cell body is located in the central nervous system, from where the preganglionic fiber runs in the peripheral nervous system, ends at ganglion, from where the acetylcholine is released. From this side, the postganglionic fiber originates and runs at the target tissue, and the released neurotransmitter is acetylcholine. The innervated tissues are smooth muscle, glands, and the cardiac muscle. There are some distinguishing features between sympathetic and the parasympathetic nervous system. Sympathetic nervous system originates in thoracic and lumbar regions of spinal cord, that is from T1 to L2, while the parasympathetic nervous system originates in the brainstem, which includes cranial nerves 3, 7, 9, and 10, and sacral region of spinal cord S2 to S4. Ganglia are located in the paravertebral sympathetic chain in sympathetic nervous system, while in parasympathetic system, the ganglia are located near or embedded within the target tissue. In sympathetic nervous system, the preganglionic fibers are short while the postganglionic fibers are long, while in cases of parasympathetic nervous system, the postganglionic fibers are short while the preganglionic fibers are long. The ratio of preganglionic fibers to postganglionic fibers is 1:20 in sympathetic nervous system, while in parasympathetic nervous system, the ratio is 1:3. Sympathetic nervous system shows divergence of neuronal activity at multiple levels of spinal cord, while in parasympathetic nervous system, the divergence is limited. In sympathetic nervous system, the activity often involves mass discharge of entire system, while in parasympathetic nervous system, activity normally involves discharge to discrete organs like spleen, like bladder, like uterus, etc. The primary neurotransmitter of postganglionic neurons in sympathetic nervous system is norepinephrine and epinephrine, while in cases of parasympathetic system, the primary neurotransmitter is acetylcholine. This figure shows that in sympathetic nervous system, the ganglia are located in the paravertebral chain and the postganglionic fibers are long, and this system shows divergence of neuronal activity at multiple levels of spinal cord, like from T1, T2 and T3, T2, T3 and T4, these thoracic nerves innervate the heart. This figure shows the effect of sympathetic nervous system to different parts of the body. Like on eye, the system causes mydvasis, that is dilatation of the pupils. On lungs, it causes dilatation. On heart, it increases the activity of heart, that is increases the heart rate, increases the contractility, increases the conduction. On blood vessels, the system causes constriction, while on GI, bladder and uterus, it causes relaxation. However, there is no effect on salivary glands. The sympathetic nervous system shows activity by binding to different types of receptors. These receptors are broadly classified into alpha receptors, beta receptors, and dopaminergic receptors. The alpha receptors are subdivided into alpha 1 and alpha 2. The alpha 1 shows action on arterioles and veins and cause constriction, while on eyes, these receptors cause mydvasis, while on penis, these type of receptors cause ejaculation. Alpha 2 receptors is basically inhibits the continued release of norepinephrine from the preganglionic fibers. It is a feedback mechanism which limits the action of sympathetic nervous system on response. Beta receptors, the beta 1 receptors have activity on the heart, and this system increases the heart rate, increases the conductivity, automaticity and contractility of the heart, and also causes renin release from the kidney. While beta 2 receptors shows action on lungs and cause bronchodilation, also causes dilatation of the arterioles, also causes relaxation of the uterine muscle and causes tremors in the skeletal muscles. While the dopaminergic receptors cause vasodilation in the brain. These adrenergic receptors follow the G protein couple receptor mechanism. What are sympatholytic drugs? These are the drugs which either block or decrease the effects of sympathetic stimulation, block or decrease the effect of endogenous catecholamines, or block or decrease the effects of sympathomimetic drugs. Sympathomimetic drugs are those drugs which mimic or stimulate the activity of sympathetic nervous system and the prime drug is isoproterenol. The sympatholytic drugs are classified into adrenergic receptor antagonists, which are so-called adrenergic blocking drugs. Other drugs are adrenergic neuron blocking drugs, central sympatholytics, and ganglion blockers. Adrenergic receptor antagonists. First, we will discuss alpha blockers. The alpha blockers, also called the alpha adrenergic antagonists, are subdivided into non-selective blockers and selective blockers. Non-selective blockers are those blockers which block the activity of both alpha-1 and alpha-2 receptors and include competitive, so-called the reversible blockers, and non-competitive, so-called the irreversible blockers. Reversible blockers are phentolamine and tolazolene, while the non-competitive, so-called the irreversible blocker, is phenoxybenzamine. Selective alpha adrenergic blockers include alpha-1 blockers, which include parazosine, terazosin, doxazosine, alfuzosin, tamsulosin, while alpha-2 blockers include yohimbine. Alpha blockers are usually used to treat pheochromocytoma, hypertension, and benign prostate hypertrophy, while these blockers bind reversibly and irreversibly on postganglionic alpha receptors and cause relaxation of smooth muscles and vasodilation. These drugs are well absorbed orally, undergo extensive hepatic metabolism. The main difference among these alpha blockers is in elimination of half-life. Parazosine and indoramin show short half-life, while doxazosine and terazosin show longer half-life. These drugs are contraindicated in heart failure as alpha blockers cause dilatation of the vasculature, leading to decreased blood flow to the heart. These alpha blockers also cause respiratory distress, leading to congestion at nasal passages, and also cause urinary incontinence because alpha blockers cause contraction of the detrusor muscle, leading to incontinence. Clinical uses and adverse effects of alpha blockers are: the non-selective phenoxybenzamine and phentolamine are used in pheochromocytoma. The pheochromocytoma is the tumor of adrenal gland which causes increased release of epinephrine and cardiac stimulation, cardiac arrhythmias, nausea and vomiting. The selective alpha-1 blockers are parazosine, doxazosine and terazosin. These drugs bind with alpha-1A and alpha-B receptors and show activity on vasculatures as well as on prostate gland. That's why these drugs are used in hypertension, Raynaud's syndrome, benign prostate hypertrophy, erectile dysfunction, and post-traumatic stress disorder. Raynaud's syndrome is associated with spasm of the arterioles, leading to bluish occurrence in the nails, toes, nose, and lips, and it is usually seen in stress condition and also in cold weather. Benign prostate hypertrophy is associated with a tumor of the prostate gland in which the sufferer experiences urinary obstruction and failing to micturate, leading to the retention of the urine. Erectile dysfunction is associated with impotency and it is usually seen in stress condition due to increased release of norepinephrine. Post-traumatic stress disorder. After trauma and injury, patient experiences stress leading to increased release of norepinephrine. In all these conditions, the selective alpha-1 blockers, which binds to both alpha-1A and 1B receptors, produce their effect. The adverse effects are first dose effect. First dose effect is a condition in which when the patient take his first dose experiences sudden withdrawal in blood pressure leading to syncope and unconsciousness. In order to prevent this first dose effect, the sub-therapeutic dose of alpha blockers are usually given initially at bedtime. This first dose effect is less common in doxazosine because of sustained release formulation. Orthostatic hypertension, so-called the postural hypertension, in which the patient experiences hypertension due to sudden rising from the bed or from sitting position. Nasal congestion is another adverse effect which is associated with congestion in nasal passages. Due to the vasodilation in peripheral regions, the alpha-1 blockers cause dizziness, headache, and drowsiness. Tamsulosin and alfuzosin are also alpha-1 selective blockers, but these drugs are used only in benign prostate hypertrophy, and it is primarily used in those individuals who are not suffering from hypertension. And the main adverse effect is orthostatic hypertension. Yohimbine is the alpha-2 blocker, and it acts as sexual stimulant. The second type of adrenergic receptor antagonist is beta blockers. Beta blockers are divided into three types or three generations. The first generation, so-called the non-selective, and binds with both beta-1 and beta-2 receptors and include nadolol, pindolol, propranolol, timolol, etc. The second generation is beta-1 selective antagonists and include atenolol, bisoprolol, esmolol, and metoprolol. While the third generation is basically vasodilatory in action and subdivided into non-selective and beta-1 selective. The beta-1 selective includes nebivolol and betoxolol, and the non-selective includes carvedilol and levedolol, and these drugs also have additional alpha blocking activity. Beta blockers and on olol and usually used to treat cardiac disorders like hypertension, cardiac arrhythmia, myocardial infarction, cardiac arrhythmias, but they are also used to treat hyperthyroidism, migraine, and glaucoma. These drugs bind reversibly at postganglionic beta receptors. Some of them show intrinsic sympathetic activity and membrane stabilizing effects. This chart shows the pharmacokinetics of beta blockers. Non-selective beta blockers like pindolol and oxyprenolol show intrinsic sympathetic activity, while in cases of sympathetic beta blockers, acebutolol and practolol show intrinsic sympathetic activity. The longer half-life is seen in carvedilol, cetrolol, and nadolol in cases of non-selective beta blockers, while in selective beta blockers, the long half-life is seen in betoxolol, bisoprolol, practolol. Some of the beta blockers are highly lipophilic, some are less lipophilic, and others are hydrophilic in nature. The drugs which are highly lipophilic in nature include propranolol, timolol, pindolol, oxyprenolol, cetrolol, and carvedilol in cases of non-selective beta blockers, while in selective beta blockers, metoprolol, acebutolol, and practolol are highly lipophilic in nature. In cases of non-selective beta blockers, propranolol and carvedilol show maximum protein binding, while the selective beta blockers show comparable protein binding. Membrane stabilizing effects are seen in propranolol, pindolol, labetalol, oxbrinolol in cases of non-selective beta blockers, while in selective beta blockers it is seen in acebutolol. These drugs are well absorbed orally and undergo extensive hepatic metabolism. Beta blockers are contraindicated in asthma and COPD because it is seen in those individuals who are taking non-selective beta blockers like propranolol. Diabetes mellitus is also seen in those individuals who are taking non-selective beta blockers. Thyroid disease and liver diseases are also seen in patients who are taking beta blockers. The clinical uses of beta blockers are: these drugs are used in cardiac arrhythmias, and the prime drugs are esmolol, cetalol, while in cardiac failure, the main drugs are carvedilol, metoprolol, bisoprolol. Other drugs which are specifically labeled for hypertension, angina and myocardial infarction are atenolol, metoprolol, propranolol, timolol, carvedilol, bisoprolol. Other drugs specifically used for glaucoma are timolol and metoxilol. Propranolol is the main drug used to treat tremors seen in patients suffering from hyperthyroidism. Metoprolol is also used in this condition, while for the prophylaxis of migraine, timolol and propranolol are used. Adverse effects are bradycardia, which is usually seen in cases of selective beta-1 blockers, while bronchospasm and shortness of breath is associated with non-selective beta blockers. Heart failure symptoms like weight gain, edema and fatigue is associated with selective beta blockers, while hypoglycemia, headache, confusion, dizziness, Raynaud's syndrome and upset of stomach. These features are also associated with non-selective beta blockers. What is intrinsic sympathetic activity? Intrinsic sympathetic activity is called the stimulation of beta receptors by partial agonists, and partial agonists are those drugs which show high affinity and low specific activity. These partial agonists stimulate beta-1 or beta-1 and beta-2 receptors, but their presence prevents the effect of pure agonists, which show high affinity and high specific activity, and the good example is isoproterenol. While partial agonists also cause less resting bradycardia, and it is well tolerated in patients suffering from heart failure, and it is safer drug as compared to pure antagonists, which show high affinity and zero specific activity. These drugs include acebutolol, pindolol, penbutolol, labetalol, oxbrinolol, and caliprolol. Membrane stabilizing effects is the complete inhibition of action potential across the membrane caused by inhibition of sodium transport. It follows the mechanism of local anesthesia and blocks the propagation of action potential across nerves, thereby producing nerve block. Includes carvedilol, propranolol, oxbrinolol, labetalol, metoprolol, and timolol. Another classification of sympatholytic drugs are adrenergic neuron blocking drugs. Before discussing the adrenergic neuron blocking drugs, we should know that that adrenergic drugs or adrenergic nervous system shows action on the synthesis of norepinephrine, storage, release of norepinephrine, binding of norepinephrine to the receptors, both at the level of presynaptic receptors and postsynaptic receptors, also associated with the metabolism and removal of the norepinephrine from the synaptic space. So, the first drug is a tyrosine. It is a drug which inhibits the conversion of tyrosine into dopa. It is a rate-limiting step, and this drug inhibits the tyrosine hydroxylase. Guanethidine inhibits the action of releasing of norepinephrine from synaptic vesicles, while Bretylium also follows the same pattern. Recepin inhibits the reuptake of norepinephrine into the synaptic vesicle, while gonadril is basically follows the same pattern of guanethidine and bretylium. Tyrosine is primarily used in pheochromocytoma with phenoxybenzaimine, while guanethidine is used in hypertension, glaucoma, severe preeclampsia. Bretylium is also used in hypertension, cardiac arrhythmia, while recepin is used in hypertension associated with diuretics because recepin causes fluid retention and edema. The third classification of drug is central sympatholytic drugs, which are so-called central sympathoplagic drugs or alpha-2 agonist drugs. The central sympatholytic drugs are those drugs which bind to and activate alpha-2 receptors. In this way, they block the activity of sympathetic nervous system. As we all know that at the level of alpha-2 receptors, these drugs, which are so-called the alpha-2 agonists, inhibit the continued release of norepinephrine from the post-ganglionic fibers, thereby inhibiting the effect of sympathetic nervous system. Includes alpha-methyl-dopa, clonidine, guanfacine, and guanabans. Alpha-methyl-dopa is a structure analog of dopa. It is a prodrug which is converted into alpha-methyl norepinephrine, which acts as alpha-2 adrenergic agonist and decrease the sympathetic outflow. Clonidine and guanfacine inhibits the release of norepinephrine on stimulation. The clinical uses are hypertension, post-traumatic stress disorder, generalized anxiety disorder, panic disorder. Adverse effects are sedation, dry mouth, dry nasal mucosa, bradycardia, orthostatic hypotension and impotency, fluid retention and edema. That's why it is used along with diuretics. And sudden withdrawal of clonidine leads to rebound hypertension. Another group which is included in sympatholytic drugs include ganglion blockers. What is a ganglion? Ganglion is a structure containing a number of nerve cell bodies, and they are located between preganglionic and postganglionic fibers of both sympathetic and parasympathetic nervous system. That is, they inactivate both the sympathetic and parasympathetic nervous system. That's why these ganglion blockers are discussed in detail in lecture dealing parasympatholytic drugs. These ganglion blocking drugs include nicotine, trimethoprim, hexamethonium, mecamylamine, and tetraethyl ammonium. So, in this lecture we have covered the overview of nervous